Yes. All right, we're on? Okay, perfect. Good morning, everyone. Happy Sunday. Happy Cinco de Mayo. Oh, no. Hold on. Okay, are we on? Perfect. Good morning, everyone. I was just saying happy Cinco de Mayo. My name is Donna. I am the host and the moderator for today's class. Welcome to our eLotus webinar. Here at Lotus Institute of Integrative Medicine, we've been holding educational seminars and webinars for over a decade, and it's been such a wonderful journey filled with many experiences and lessons taught by speakers who are not only experts in their respected fields, but more importantly, they're willing to share their wealth of knowledge with all of us. We believe that the future of TCM and the advancement of Chinese medicine can only be obtained through continued growth, learning, and progress. And that's our goal here at eLotus, and we're so glad that you're joining us today. So before we get started, I just want to say a huge sorry to our California acupuncturists. This class originally, as a bloodletting course, it was not approved by California because previously they said anything bloodletting, no. So I didn't even try. But you know, I thought, what the heck? I'm going to go ahead and submit the application and let's see what happens, and cross my finger, and lo and behold, it got approved. So this class is approved by California, so I'm really sorry to stress anyone out on a Sunday morning. So sorry. I thought I got all the little notes about it not being approved. I thought I had cleared that out from the email, but it looks like I didn't, and again, I do apologize. The class is approved by California for eight credits today, and I believe on their website someone mentioned that it says it's for distance learning. That's not correct. It's for live, and if you need to see the proof of it, I'm more than happy to send it to you as well. Okay, so a little housekeeping before we get started. Oops, what you are seeing on your screen. On the top left-hand corner is the video feed, and to the right of the video feed is the PowerPoint for today's class, and I made 2 downloads available for you. You can decide if you want 6 slides to a page or 2 slides to a page. And on the bottom, you see 2 boxes. The first box to your left is the chat room, and here in the chat room is where you can connect with your colleagues who are also attending today's webinar live. If you see someone that you want a private chat with, you can do so by clicking on the menu icon on the top right-hand corner of the chat room, and then you can select who you'd like to private chat with. If you want to connect with me or the tech, if you're having any technical issues, please send your private chat to the host. If you send your private chat to the presenter, no one actually monitors that, so don't do that. Just send it to the host or to your friends. And to the right of the chat room, you'll find upcoming events here at eLotus, as well as information about today's class. So do take a look at that little box periodically throughout the day. And if you do experience any echoing by any chance, that's because you may be logged in more than once. So if that happens, just go ahead and close the extra logins, or after a period of time, Adobe does remove the extra logins for you. And if you do experience any slowing, skipping, or stopping, sound issues, video issues, it usually happens to people who are on a wireless connection because it's wireless. It goes up and down. You don't know what you get. It's pretty much up in the air. So we do recommend for the best internet from your provider to connect directly using an Ethernet cord. If that doesn't work, we're here to help you. I've attended a lot of webinars, so I have a lot of great advice, as well as our tech Sam. So please connect with us so that we can help you personally. Okay, so it looks like we're about ready to get started. That's all the housekeeping, I believe. Yes. You know what, just for fun, can you guys type into the chat room where you are watching from? That way when Dean gets back to his chair and then he looks on the screen, he sees where he has an idea of where his viewers are. So just go ahead and type it in. So we have, I'm just reading it off to you. We have Panama, Oregon, Texas, California, someone's living room. Oh, I want to go there one day. Virginia. Awesome. Thank you guys for doing that for me. So today's class is Tung-Style Bloodletting for Real Relief with Dean Mouscher. And Dean graduated from the Midwest College of Oriental Medicine. After learning that Master Dong bled 40 to 50% of his patients, he devoted himself to the study and practice of this ancient art and was amazed at how quickly bloodletting was able to resolve stubborn cases that no other therapy has been able to touch. For the past several years, he's specialized in Master Dong-style bloodletting, studying it extensively and bleeding more than half the 80 patients he sees every week at his busy Chicagoland clinic, gaining vast experience and expertise in this nearly lost, unfathomable, powerful healing art. And we are so glad that you guys are here and you're going to learn it because it's awesome. We were just talking about it at dinner last night, how satisfying it is to watch the black blood come out and then it turns red. It's way better than Dr. Pimple Popper. I think so. All right, let's go ahead and welcome Dean.
All right. Okay, let's see where everybody's from. New Southwest Australia, so I guess I'll have to speak in metrics too. So, all right. Well, welcome everybody. Thank you for coming and spending your Sunday with us. And thank you to Donna and to Tina for organizing this and inviting me here so I have an opportunity to talk all day about my favorite topic, which is bloodletting. And the reason that I love bloodletting and love talking about bloodletting is because my favorite thing is when a patient comes in and has been to every doctor and every physical therapist and every chiropractor and massage therapist and can't get relief. And then he comes in, and then as a result of something I do, he gets up off the table and he says, wow, that's so much better. That's my favorite thing. And the thing that provides that result more often than anything else, by far, in my practice, is bloodletting. And ever since I started bloodletting, that happens a lot more often than it used to. And I thought I was a pretty good acupuncturist before I started bloodletting. I was following Dr. Tan since the year 2000 and learned a lot of different systems, his system, other distal acupuncture systems, auriculotherapy and Korean hand therapy and other things, but really nothing compares to the power of bloodletting. It is truly magic. So the thing about bloodletting is it hasn't been, I feel it's way underutilized. It's definitely way underutilized. It's barely taught at school. It's like the black sheep of the TCM family. People don't do it, they don't talk about it, and I think part of the reason is people just aren't comfortable with it. They don't know what's safe, they don't know what's legal, and they don't know what patients are going to accept. So really the most important thing I hope you get out of today is to feel comfortable with bloodletting so that you start doing it in your clinic, or if you're already doing it a little, you start doing it more. Because really there's no reason not to be doing it a lot more. I do it all the time. It's quick, it's easy. Patients accept it very easily if you do it right, if you use the right tools and the right techniques. So there's really no reason that it should be this black sheep of the TCM family. And so there's a support group on Facebook. It's called Chinese Medicine Bloodletting. Please join. That's where we do support for bloodletting. People post pictures and ask questions and post case histories and post their successes and their failures and ask questions and answer other people's questions, and we pool our results. So if you haven't joined yet, please join. Okay. So in order to be doing, in order to make it possible to do bloodletting more, one concept that I've been getting into is minimally invasive bloodletting, I mean, when I first started with bloodletting, I thought bloodletting, you know, it's this macho, you know, sort of extreme Chinese art, and I would have to steel myself and prepare my patients to really, you know, go deep and get a lot of blood. And that was what I thought initially. But the longer I do it, the more I'm going the other way. The more I understand the opposite is true. And really, the more gently you can do it, the better. Now, a lot depends on the patient. So if you're bleeding veins in the leg, for example, one of the regions to bleed is, we're going to talk about the 3 main regions to bleed and the other ones too. One of the main regions to bleed is the leg. When you're bleeding legs, you're bleeding veins, generally speaking. And exactly how you do it depends a lot on the patient and on the presentation, what kind of veins they have in their legs. So, but if they have superficial veins and deep veins, these days I'm more likely to go for the very superficial veins. For one thing, what I've learned is you don't need a ton of blood. I used to think and hear that, you know, the real great bloodletters would, you know, fill up a bathtub full of the patient's blood that they would have to prepare and fill up a plastic tub of blood. And that's just not true. It turns out that it's not, the effectiveness of bloodletting is not dose dependent. It's not like you get a little blood and it's a little effective, and you get a medium amount of blood and it's medium effective, and you get a lot of blood and it's really effective. It's not like that at all. If you can hit a vein and get, in the classics it says a drop the size of a bean. And really that's all you need. If you can, you know, hit that vein, get a good sized drop, generally speaking you'll get more than that. But if you can get a good sized drop, a little bit of flow, that's enough. And you'll get what you'll get the results you get. And if you get, you know, 10 times more blood, it's not going to be 10 times more effective. It may not be any more effective. And if you've turned off the patient, then it's going to be less effective because they're not going to come back. So one reason that gentler is better is that it makes it doable. You know, if you just do it superficially, then you don't cause a bruise, you don't cause any, the patient doesn't feel it, no discomfort when you do it, no discomfort later. They come back, you know, hey, that worked. Please do that. Please do that again, what you did last time. And it's just as effective. So I want to run the first video in just a moment, and that's of my patient Eric. I've been posting online a little bit about him because we had a really good result. He's a mechanical engineer. He's a huge guy. He's 6'6", which is 2 meters for you people not in the U.S. And he's 47 years old, and he came in at the end of February, and he had a really bad case of peripheral neuropathy, non-diabetic peripheral neuropathy, unknown cause. And he was really miserable. Maybe he wasn't in the most pain of any patient I've ever had, but I never had anybody more miserable than him. He was so unhappy that he had this at such a young age and wondering if he was going to have to live like this the rest of his life. And I treated him, the first few times I treated him with an infrared laser, which is what I've done for a long time for peripheral neuropathy, and it works pretty well. And he did say he got better, but he was just as unhappy. So on the on his third visit, and also he had, and you'll see, for a 47-year-old guy, he has a very unusual number of network of spider veins in his lower legs. You know, a clear sign of blood stasis. So he has the spider veins and he has this weird peripheral neuropathy. So it paints a picture of blood stasis. I was a little hesitant to bleed him because he's so negative and so full of complaints. I was afraid he was going to complain if there was any bruising and complain if he felt any discomfort, but I felt I had to do it. So I bled him very superficially. And the very next day he texted me and he said, I got this text from him. I thought, oh boy, here it comes. And I looked at the text and it says, that bleeding you did yesterday really worked. Can we do that again tomorrow? And that was like the first positive thing I'd ever heard out of this guy. And he came back and I said, how are you doing? He said, actually pretty good. And And he says, now I was able to take a shower, you know, stand on a hard floor, and it wasn't that bad. And so I've been doing that since, and I think this video you'll see is the third or the fourth time I bled him. And you'll hear him say that after 3 or 4 bloodlettings, and you'll see it's pretty easy, pretty superficial, not very deep or extreme at all. He says his pain is almost gone, which is an incredible result. So and will I be able to see the video? Okay. Okay.
So you have to play that one for now.
Oh, okay.
So 1, right?
1, yeah.
This one?
Yeah.
No voice, right?
There is voice. Yeah, there should be voice.
It's to the point where it was tough for me to wear slip-on shoes, and we started to know the point is it seems to have greatly subsided. I'm getting feeling back across the lateral part of my foot, and trying a bunch of different methods, but this seems to have really excelled the healing process, I guess you would call it.
Okay. And since the last time, how would you say it's been?
I went from varying degrees of numbness and pain to, after the last treatment, again, it was about a week ago, I had a really good week. It seems that the pain is going away, and it's been staying away. Not to say that I don't have pain sometimes, but that was literally all the time to, frequently to now it's infrequent. So we'll see.
So the pain is infrequent, so most of the time you have no pain at all?
Correct.
That's great. That's incredible compared to what it was like when you came in.
Yep. And I hope it's all gone.
That is an incredible result. All right. And I remember the hardest thing for you was wearing dress shoes, right?
Wearing dress shoes.
So you're back to wearing dress shoes now?
I had construction boots on all weekend because I was working in the yard. Before it was really tough to wear those, to where I had a little bit of discomfort on Friday. Saturday, really none at all, and Sunday was fine.
That's amazing.
So I'll be wearing dress shoes starting tomorrow through the end of the week, and we'll see where we get.
Okay. Would you say the construction boots were even worse?
They were anything that was a tied shoe where you're putting pressure across the top of the foot would cause the ball of the foot to have.
All right. And we're just going to, so you'll see that I edited this, and then you'll see at the very end, after it stopped, you'll see that, you see there's nothing there. It was a tiny little mark, no bruising. He comes back, you can barely see where I was. All right. All right, let's see. Okay, why is he bleeding so much? Is he on meds? So he wasn't bleeding. He wouldn't have been bleeding that much. You may have noticed that I kept wiping it. That was actually an alcohol wipe. That cotton was soaked with alcohol. So I was wiping it to prevent a clot from forming, and that's why he kept bleeding. Otherwise, it would have stopped. On the first leg, you may have seen it bled very briefly and stopped. But on the second leg, I just wanted to demonstrate the technique of getting a little more blood by wiping it with an alcohol swab. So that's why it kept going. But no, he's not on blood thinners. It would have stopped had I not kept swabbing it with that alcohol swab. Okay. Okay. Alcohol on cotton. Yes, that's correct. How do you stop the patient from bleeding? I never stop the patient from bleeding. I always let the patient stop himself. Now, if I felt that the patient was in danger, I would stop. But I haven't actually found that yet where I had to stop. And you're going to see somewhat later on in the presentation, the most extreme bloodletting I ever did, I didn't mean for it to be the most extreme, but I pricked this woman's vein, which was under a lot of pressure, and it spurted for 8 minutes straight. And I happened to have a camera going by a lucky coincidence. It wasn't a completely lucky coincidence. She had done this once before, and that's why I set up the camera. So I guess I just got lucky. But I edited it, so I'm not going to make you look at it for 8 minutes. Maybe it's 2.5. But it spurts for 8 minutes. And I let it go. I let it stop on its own. Now, how did I have the confidence that she wasn't going to bleed to death? Well, a little piece of bloodletting equipment, which I now find essential, is a paper cup for just such cases. And you'll see, I had a paper cup ready, and I caught every drop in that paper cup so I could see how much she had bled. And had you just been looking at her spurting, you would have thought it was a lot, but it was a very thin stream, so when you looked in the cup, it wasn't that much. Maybe by the end it was 100 milliliters. And when you donate blood, you know, you go to a blood bank and donate blood, they take about 500 milliliters. So it's 1/5 the amount that they'll take from anybody, basically, who wants to donate blood. So that's the most I ever got, and still it's a safe amount. Generally speaking, I don't want to stop the bleeding because, well, for two reasons. One, because I want to let the body bleed as much as it wants to bleed. I mean, who am I to tell the body how much it needs to bleed? And secondly, if you stop the bleeding, there's a risk that it'll open at home. If they disturb the clot at home and it'll start bleeding, it'll freak them out. And that's happened to me. That's how I know. And then you get a phone call late at night, or they come in the next time and they tell you, wow, I was really freaked out. If you just let it bleed until it stops on its own, that won't happen. Where do you purchase your Lancets? So what I was using, my favorite instrument to use for bleeding veins in the leg, we'll talk a lot about bleeding instruments and needles later on, but my favorite is a hypodermic needle, 20 gauge, 1.5 inches, and McKesson doesn't make that. McKesson is a good company. They make good hypodermic needles. That particular length and gauge, I think only BD, Becton Dixon, makes. So I use that one. And let's see, where do I purchase them? I mean, you can go online. There's a place called healthykin.com that I buy them from sometimes, but you can just Google them and buy them from whoever is offering them most cheaply at that time, which will change from month to month. Do you charge extra for bloodletting? Nope, that's part of the service. I mean, I do have, in my practice, I have a short appointment and a long appointment, extended appointment. And the short appointment is if somebody just comes in, let's say they have, they're suffering from anxiety. I just put needles in, or else I'll quickly bleed their ear and put needles in, and that's a short appointment. If I need to bleed their leg or do something more extensive, then it's a longer appointment. So it goes by time, not by, what procedures I do. Do you puncture the same location every time? No, not exactly the same location. You want to go to different locations. Healthywho.com. Healthykin. It's healthy, K-I-N. One word. Healthy, and then K-I-N.com. It's a weird name. Okay. So let's see. All right, so how did I get started bloodletting? So like I told you, I was a big Dr. Tan fan back in the day. I went to my first Dr. Tan lecture in New York almost exactly 19 years ago in May of 2000, and I was smitten. And I became a Dr. Tan groupie and followed him around and went to a lot of his lectures all over the place. And I don't think that there were webinars back then. So I actually had to go places. I went to Boston and different places. Sometimes he would come to Chicago, where I'm from. And I do remember that just one time he talked about bloodletting in all those Dr. Tan lectures that I attended. And somebody had asked him about high blood pressure. And he says, well, high blood pressure, and he gave a few points, and he said, yeah, but really, high blood pressure, sometimes you just have to bleed them. You don't need enough, you don't need much, you just a few drops of blood, and it's like pulling the plug, you know, it's like pulling the plug and then the blood can flow. And that stuck with me. I thought, bloodletting, wow, that's weird. But then many years later, I became interested in Master Dong bloodletting. Everybody was getting into Master Dong bloodletting. So I bought a book by Wei-Chia Young, who was his senior apprentice in Taiwan and now lives in California. And I bought his book, and I was reading through the introduction. And he started talking about, well, you know, what makes a qualified acupuncturist? And and I thought, oh, am I a qualified acupuncturist? And I was qualified for 4 of the 5 criteria, but the 5th criterion was bloodletting for chronic and difficult diseases. And I thought, bloodletting? I don't do bloodletting. I didn't know anything about it. And this is what he wrote. He wrote, blood stasis occurs in protracted, difficult, and odd diseases for which bloodletting is the best way to solve the problem. If properly conducted, unimaginable effects can be seen. Any acupuncturist who is not familiar with bloodletting cannot be viewed as a proficient one. That was like a knife in the heart, because I didn't do bloodletting, and I thought, I'm not a proficient acupuncturist. And I realized, you know, I guess I had always thought up until then, because, you know, I did all these distal acupuncture methods, and I thought it was just, you know, doing effective acupuncture is always a matter of finding the correct points. It's always just a matter of, and if you find the correct points, you will solve the problem, no matter what it is. And then I had this epiphany, and I realized, you know, that's apparently not true, because Master Dong knew all the right points. I mean, he was the master at knowing where to needle, but 40% of the time, he did bloodletting. So 40% of the time, nearly half of his patients, he felt acupuncture alone wasn't enough for the job. He needed to do bloodletting. And by all accounts, that was not just any 40%, it was probably his most difficult 40%. And I had this epiphany. I realized that there's all this legend about Master Dong and how great he was, and like this legend that grew up around him in Taiwan about how he could solve, you know, the most difficult problems. This wasn't just Master Dong acupuncture that did this. To a large extent, if not the largest extent, this was Master Dong bloodletting. And I realized that, you know, trying to approach Master Dong's effectiveness without Master Dong bloodletting it would be a hopeless endeavor, because without bloodletting, it's not Master Dong acupuncture. So no way to approach his effectiveness without bloodletting. And I was thinking about this, and I was thinking about that. I mean, this really stuck with me and bothered me. I didn't know. I knew I had to learn bloodletting, but I really didn't know how to go about it. And about a week later, the universe sent me the perfect patient, as sometimes happens. And he was this big guy, and he really limped into my clinic, grimacing in pain with sciatica. He had left side sciatica, and I saw this guy walking into my clinic, and I saw the way he walked and grimaced in pain, and my heart sank, and I thought, oh my God. And I did acupuncture on him as best I could, but not surprisingly, he got up and he grimaced just as much. It wasn't working. And I thought, all right, well, here it is. I got to try bloodletting on this guy. And I really didn't know how to do it or anything, but I thought, if I don't do it on this guy, I'm never going to do it. So I had him lie face down, and he was wearing shorts, and I looked at his left UB40, and he had this, this perfect, incredible purple spider web of purple veins. And I don't think I was even wearing gloves. I had no idea what I was doing. And I took a Lancet. I took a safety Lancet, which is the wrong thing to use. And I kind of closed my eyes, and I let it go. And incredibly, I hit a bullseye, which is very difficult to do. I mean, it was just luck. And the blood, I mean, this black blood started oozing out, and my heart is pounding, and I was terrified. And I'm thinking, oh my God, I hope this guy doesn't die right here on my table. I was really scared. And just at that moment, he goes, oh, I don't know what you're doing, but whatever it is, don't stop. That tightness is really coming off my thigh. And I was just blown away. I thought, wow, I didn't even do anything. I mean, a few drops of, more than a few drops, but not that much blood came out. And that was it. I was hooked. I mean, the guy left. He had like, I don't know, he had a lot of relief. He was smiling when he left. And I thought, okay, this is it. This is my path. I have to learn this. And so it sort of became my obsession. And for the next several years, I bled almost every patient because I was thinking, I got to know this. I got to know when it works. I got to know when it doesn't work. So I bled everybody. And a lot of times it didn't work. And I looked, for information, and not that much was available. I mean, there was some information available, but really nuts and bolts information, what to buy, exactly how to set up, how to do it, what veins are safe to bleed, what veins are not safe to bleed. It wasn't really available. So I just looked around, bought all kinds of needles, medical needles, Chinese medical needles for bloodletting. I experimented with them. And one thing I found that was very helpful was I realized that, something very similar exists in Western medicine, namely phlebotomy. I mean, they've been doing phlebotomy for a long time, and they do it tens of thousands of times every day, and nobody dies from it. And they do it on patients, on pregnant women, and they do it on patients who are on blood thinners and who have bleeding disorders. And the people who do it are, not extremely well trained, so it's not that difficult. I mean, they have a lot less training than we have. So I studied phlebotomy, and that was really a source of a lot of good information, especially safety information about how to do bloodletting safely. And I looked up, every now and then there are lawsuits against phlebotomists, and that was very interesting because it shows you what's the worst thing that can happen and how to avoid it. So anyway, at the end of the day, it turns out bloodletting does not need to be fringy. It doesn't need to be, like in the back room hidden. Because if you use modern instruments, if you use modern techniques, bloodletting can be very easy to do, very gentle, very readily accepted by patients. I'll show you how to talk to patients, and I mean, it's just a piece of cake. Painless and safe. So I really hope that after today, all of you start doing bloodletting a lot more, and hopefully, we can spread the word and start having and see it used a lot more. It's painful for me to realize how many people every day go into acupuncturists and leave without the acupuncturists who are not doing bloodletting, and leave without getting the relief they could have gotten just because that acupuncturist doesn't know how to do bloodletting or doesn't feel comfortable doing bloodletting. Because bloodletting really is possibly the most powerful practice in all of Chinese medicine. We really have to be doing it. So Wei-Chia Young was right. If the problem is blood stasis, and very often it is, there's nothing like bloodletting to do the job. You know those patients, the really difficult ones that you just can't break through no matter what you do. And a lot of those are internal complaints, endometriosis, reflux, gastrointestinal difficulties that you just can't really get quick results with acupuncture. Many of those will respond like magic to bloodletting. So let me introduce, I'm going to show video 2 and video 3. These are testimonials of patients. Video 2 is a patient named Mark. He is in his 70s, and he has suffered all of his life with gastroesophageal reflux disease and just generally with digestive disturbances. All right, so can we roll video 2? All right, this is patient MM. Could you describe what the problem when you came in that you came in for?
Yes, I have consistent acid reflux, and almost anything I ate, some things are worse, but almost anything I ate caused acid reflux. During the day, but especially at night, it became a major problem.
And how long have you had this?
I've had this since childhood, really.
Okay, and I take it you've tried different things for it?
Oh, yes, yes, absolutely. And I go on diets occasionally, and diets do help. If I eat practically nothing, then it's better.
Okay. And we did acupuncture for a little while, and that helped a little, right?
Yes, yes, it did.
And then I guess last time or 2 times ago?
2 times ago, yeah.
We started, I pricked some veins in the leg and took a few drops of blood. And tell me if that made a difference.
The first time it was questionable. The second time it was really amazing. I came in, you had mentioned the first time that it has immediate effects as well as long-term effects. And it just so happened the second time I came in, I ate a donut, which is really bad for my reflux. Before I came in, I had bad reflux. You did the bleeding and then the acupuncture, and by the time I walked out, I had the acid reflux was gone. There was no bloating. I felt better. My stomach felt better than it had for a long, long time.
So is that an unusual result for you?
Oh, absolutely. Yeah, yeah. Once you get it, it just time alone. I mean, there's medicines you can take and stuff, which I try to avoid, but even medicines aren't very good at solving this. It's mostly just time.
So this worked better than the medicine?
Oh, absolutely. Yeah, I've never had anything work that well or that quickly.
Okay, and that was about a week ago?
That was exactly a week ago.
Okay,
right.
and how has it been since then?
It's been very good. Like I told you, I've been on kind of a strict diet, but this last week, because it was good, I tried it. Last night I even went to a new barbecue place, and normally that would kill me and I would stay up all night. Last night I had no problems at all. A little bit of indigestion, but none of the major reflux that I usually have. So it's been very good.
Okay, all right, great. Well, thank you very much.
Okay, thank you.
Okay, and then I'll just play you one more quick one, which is Molly. She's a... All right, so this is patient MD, and you came in last week for the first time, right?
Correct.
And why don't you just go ahead and talk about the endometriosis and...
Sure, I've had endometriosis, now diagnosed for only a year, but I've been suffering for 10 years. And I've had pain in my stomach. It just feels like it's very tight and crampy all the time. I have a decreased appetite because of it. A lot of pain associated around my periods as well. And then prior, I came in for the acupuncture, and that day, during even the treatment, it felt like an ice cream cone, and it was just melting away all the pain in my stomach.
So you had, prior to this, you had some discomfort, abdominal discomfort all the time?
Every day, all the time. Yep.
Okay, and
Never.
the first thing we did was I had you lie down, and I pricked the back of your leg, took a few drops of blood, and what did you feel as I was doing that?
Like it was melting away. It was the weirdest sensation, but I could actually feel in my stomach where it usually hurts on a day-to-day basis. It was just like dissolving, I guess, and I haven't had any pain since.
And prior to that, was there ever a time that you had zero pain?
No, never.
And what was the range of the pain?
I mean, it ranged all the time. It was never a solid number, you know, so it would be 2 here, it'd be 3 here, it'd be 10, 5. It was all over the place, and I can say that I have had 0 since.
Okay. All right. Well, thank you very much.
You're welcome.
How long they last, the effect, the relief?
Okay, so the question is, how long does the relief last? And that's very individual. Right now, I have an ALS patient who has a very strange nerve pain on his right side, and it goes down his neck and his shoulder and his arm, and it's very painful. And I've been seeing him twice a week, and every time I bleed his ear apex, and he gets great relief. But it only lasts for 2 or 3 days, so that's why I'm seeing him twice a week. Other people, it can last a very long time, so it's very individual. If people ask me how long is it going to last, I say, well, let's do it a few times, and then I'll know based on experience, because it's different with everyone.
About the GERD patient, how long was the relief?
Boy, let's see. I haven't seen him in a while, so he's been lost to follow-up. But it lasted all week. I'd say 2 weeks. I think he got relief for 2 weeks.
Because I have GERD.
Oh, okay. So I have a question. Where did you bleed? So I bled his legs, and my rule is, I mean, there are these regions in the leg. Forget about points. You know, you don't bleed stomach 36, or you don't bleed liver 7. You look for veins and you bleed what you see. And there are regions in which you look for the veins. And that's suggestive of where you're likely to find the best veins, but it's not absolute. So my rule is bleed what you see, wherever it is. So, you know, look on your legs, see where you have the darkest, you know, signs of blood stasis, and bleed there. This patient was a little unusual because he had the blood stasis, which I know because he got relief when I bled him, and he was 70 some odd years old, maybe 77. He was well into his 70s, and he barely had any veins. He had one, you know, it was really hard to find his vein. It was the only vein I could find was it was a very faint green vein. It was so faint I wasn't, you know, sometimes you're not even sure if you're imagining it or if it's really there. So he was a little difficult to bleed, but usually with patients with blood stasis, you'll see the blood stasis, and you bleed that. Okay. So yeah, so both acid reflux, Tammy, both of those patients, I bled their legs. The endometriosis patient, I bled behind her knee, UB40 area. For vertigo, dizziness, you can try bleeding the apex of the ear for vertigo or dizziness. Are you suggesting bleeding spider veins and varicose veins? Okay, we're going to go into this in depth. Varicose veins are something that you need to bleed for, but you do not bleed varicose veins. Now, let's get our terms straight, because different people mean different things by varicose veins. Sometimes people point to spider veins and say, look at these varicose veins. Those are not varicose veins. Varicose veins are those, and I have a lot of pictures, you'll see them. But varicose veins are those big, ropey, bulging, protruding veins. You don't bleed those. It will not help. You'll get a lot of blood because the valves in those veins are diseased and not functioning, and it doesn't have any therapeutic effect. It just may make the problem worse. However, on the same leg, anybody who has varicose veins, those ropey, bulging varicose veins, on that same leg, you will almost certainly find flat, dark spider veins. You bleed those, and it will have an immediate effect. All of my varicose vein patients who I've bled are very, very, very happy with the result. And right away, I'll say, do you have any pain? And they'll say no. And then I'll bleed them, and they'll say, it feels lighter. And they didn't even realize that they had this heaviness until I bled them. All right. So let's get right into bloodletting now. Let's talk about key bloodletting concepts, some of the main things you're going to have to know to actually start doing bloodletting. Okay. Let's see. So we're going to talk about which side do you bleed. We're going to talk about the 3 different types of bleeding. We're going to talk about the 3 main areas of the body to bleed. Something that everybody wants to know is how much blood do you need? How much blood should you get? We're going to talk about a blood stasis constitution, the type of patient who constitutionally is prone to developing blood stasis. We're going to talk about nerve conditions and nerve pain, which is where bloodletting really shines. Whenever somebody comes in and it's a nerve problem, I get all excited because I'm pretty sure that bloodletting is going to work. That includes, radiculopathy down the arm. That includes sciatica. That includes trigeminal neuralgia, optic neuritis, all kinds of nerve problems. So nerves, and I guess, you don't bleed arteries, but wherever there's a nerve, there's an artery, a major nerve, there's usually a major artery right there. So nerves and artery, or nerves and blood and bloodletting seem to go, hand in hand. We're going to talk a little bit about how it works, and is it within my scope? Now, I'm not a lawyer, so I'm going to not spend a lot of time on this, but just a very brief discussion about that. All right, so which side do you bleed? So bloodletting is pretty much always ipsilateral. It's one of the more consistent rules in Chinese medicine. There are always exceptions to everything, but generally speaking, in rare cases, maybe you'll bleed contralaterally, but generally it's always ipsilateral. And this is the opposite of Master Dong needling and Dr. Tan needling, which was mostly contralateral. So Master Dong generally needled contralaterally, but he pretty much always or almost always bled ipsilaterally. Now, I said here this is very consistent. I know of no exceptions. So, of course, as it would happen yesterday, a guy posted in the bloodletting group, and again, it's a Facebook group. It's our support group, Chinese Medicine Bloodletting. And he posted that he had a patient with a knot in his or her leg, and she didn't have any spider veins on that leg, but she had a lot of spider veins on the opposite leg. And he bled that opposite contralateral leg, and he said that she got immediate relief from the knot. So I'm not surprised. I mean, there are exceptions to everything, but I will say that that's rare. But always keep an open mind. Don't take anything I say as gospel. Always be willing to. I want to get you started, but then you're on your own. Experiment. Don't be afraid to disregard anything I said and experiment. All right, so let's talk about the 3 types of bleeding. So according to Western medicine, in phlebotomy, if you study phlebotomy, you learn that all bleeding can be categorized in 3 types of bleeding: capillary bleeding, venous bleeding, or arterial bleeding. All right. Let's talk first of all about arterial bleeding. Now, in phlebotomy, there is sometimes you need to get an arterial blood sample. Some tests will call for an arterial blood sample. So you actually have to. Now, arteries are under pressure, as you know. The heart pumps, it sends the blood out through the arteries, and then it goes to finer and finer and finer veins, and then capillaries, and then delivers its oxygen and nourishment to the cells, and then it comes back to the heart through the veins. So the arteries are tough, they're under pressure. In Chinese medicine, you never want to puncture an artery. There is no reason for that. Now, that's an absolute rule. You never want to puncture an artery. There's no therapeutic reason for puncturing an artery. You'll know. How do you know if you've punctured an artery? Well, the blood, remember, it's under pressure. Every time the heart contracts, it sends the blood under pressure through the artery. So it'll spurt with every beat of the heart. If you go on YouTube, you can find some nice videos of that. And it's bright red because it's oxygenated. It hasn't delivered its load of oxygen yet. So it's bright red, spurts with every heartbeat, and it's very unlikely you will ever puncture an artery if you observe, minimum cautions. But if you do, it's probably not a disaster. Like I said, phlebotomists do arterial punctures. You know, there are lines that can be installed that are where you puncture an artery. And you just have to put firm pressure on it for 10 minutes or more and until it clots and holds firmly, and then put a pressure bandage on it. All right, so we'll cross out 3. There are 2 types of bleeding. We'll cross out arterial bleeding, and we'll leave capillary bleeding and venous bleeding. So capillary bleeding. So capillary bleeding is, you know, if you just puncture the skin anywhere or cut yourself anywhere, a little blood will come out. Okay, that's capillary bleeding because there are capillaries everywhere. So if a diabetic pricks his finger, that's capillary bleeding. You know, in acupuncture, sometimes you'll take a needle out. You'll take a needle out of the ear especially, or the fingers, or anywhere. You might get a little blood, a drop of blood. That's capillary bleeding. And that's, you get very little blood. So wet cupping is capillary bleeding, and we're going to show that a little later. And you just, you prick a few times. And so since you get so little blood when you prick with a lancet, you typically use a cup, a suction, you know, a cup, and the suction helps pull out blood. So when so wet cupping capillary is capillary bleeding, and capillary bleeding is wet cupping for the most part. Generally speaking, if you're going to do capillary bleeding, you're going to use a cup. Exceptions are the ear, the finger. You don't use cups there, obviously. There's a spot on the back of the neck that is incredibly effective for nausea, and it's above the hairline. You generally don't have to cup there. You can squeeze out a little blood, and it's still very effective. You can't really cup because of the hair. Okay, so when you bleed the back, that's generally capillary bleeding. So here's a back, in case anybody forgot what a back looks like. This is a typical back. And you can see there are no veins. There are nothing to see there. Sometimes a little hair or a mole. But sometimes, especially with older people or people who are a little obese, you may see veins. But more often than not, this is pretty typical of what you'll see. And yet, and when we're going to talk about this, Master Dong had a very highly developed system of bleeding the back. And that is capillary bleeding. It's wet cupping. So we're going to show that. All right, so here's, I'll actually show you the video that this came from a little later, but this is what a back looks like after 5 pricks with a diabetic lancet. You can see 1, 2, 3, 4, 5 little drops. You're not going to get much just with those diabetic lancets. There are safety lancets, and we're going to talk about that. Those safety lancets are great. The safety lancets are one of the things, it's a modern tool, it's one of the things that makes bloodletting so easy and so acceptable to patients. They don't even feel it, but you really need a cup to get out a decent amount of blood. So here I put a cup on, and you can see it's pulling out a little bit more blood than, than would have come out without it. All right, so we've discussed arterial bleeding, which you don't want to do. We've discussed capillary bleeding, which is usually wet cupping. So now we're going to talk about venous bleeding. Venous bleeding, not surprisingly, is when you prick a vein, and you get blood directly out of that vein. And here's an example. This is a woman in her 70s, and she has really nice, dark spider veins that are very easy to bleed. And you can see how dark the blood is as it comes out. By the way, I forgot to mention on my mechanical engineer, you can see the blood coming out It was pretty red, actually. Now, if you looked at an earlier video of me bleeding him, the blood was much darker. Here, this is a woman, I don't bleed her very often. I think I actually have a video of bleeding her lower leg a little later. So it's very dark. So again, this is a hypodermic needle that I'm using. And so when you bleed veins, when you do venous bleeding, usually you don't palpate. You do it by eyesight. Your eyes are your guide. Your eyes tell you where you want to bleed. And let me just see if there are any. And let's see. So one difference between venous bleeding and capillary bleeding is you don't need to use a cup with venous bleeding, okay? So like with a patient like this, I prick her veins in her leg. No need to cup. Waste of a good cup. Absolutely unnecessary. All right. So, okay, I have a question. Would you bleed a patient with DVT? The first thing I would do, if I suspected DVT, is send the patient to a physician. DVT is no joke. Somebody was saying on the bloodletting group that they didn't want to send a patient to a physician because blood thinners are so difficult, are so dangerous, and they can cause death. Well, pulmonary embolism can cause death too. You want to stay far away from a patient with a DVT until they're being treated by an MD. At that point, yes, you can bleed them. All right, let's see. So venous bleeding differs from capillary bleeding in a number of ways. You use a different needle. Remember, you use if you're going to do bleeding veins, you don't want to use a diabetic lancet. They're too short. You want to use a more substantial needle, like a hypodermic needle, or possibly a piercing needle. Cupping is not necessary. It's a completely different technique. Instead of using these spring-loaded safety lancets, you actually are using, and we'll show this, you're actually using the needle and manually pricking what you see. And again, bleeding legs, this is venous bleeding that we're talking about. All right, you mentioned collecting a long bleed in a paper cup. Could you explain how you did do that? I'll do better than that, Dennis. I will show you a video of me doing that. And it's not hard. I mean, it's spurting. You just hold the cup where the blood is coming, and it goes right in it. All right, so here's a 20 gauge, 1.5-inch hypodermic needle, my very favorite instrument for bloodletting, for venous bloodletting. This one is made by BD, and it is razor sharp. It works really well. Often the patient doesn't even feel it. I will mention that it's very good to stretch the skin before you do it. You'll see me doing that in videos. You stretch the skin. If you don't stretch the skin, sometimes when you go in with the needle, you just depress the skin at first, and that hurts. But if you stretch the skin and you go in, it just goes in like butter. You can also use 18 gauge needles. I've experimented with 18 gauge, 20 gauge. You get a little more blood with the 18 gauge. The 20 gauge goes in more easily. So these days I'm sort of favoring gentle, the gentle over quantity. 22s, of course, are even thinner, but they're a little too thin. That 20 gauge I find to be a very good compromise, very good size. All right, so let's turn to, let's see, how deep are you going with venous bleeding? Well, that depends on the vein, depends on how deep the vein is. Hopefully you will find really superficial veins, like those ones on Linda just a moment ago, or the ones on Eric earlier. And With those, you go in, I mean, a millimeter. Sometimes they're so superficial. I mean, the other day I was positioning my point and I didn't even mean to prick, and blood started coming out because that thing is so sharp. It went in maybe half a millimeter and that was enough, and blood started coming out. So if you are lucky enough to have a patient with really superficial veins, you can go in, you know, a millimeter, a half a millimeter sometimes. You go in as little as necessary, I would say. Yes?
How about wet cupping? Do you have to create a vacuum first?
Okay, the question is, when you wet cup, do you create a vacuum first? So sometimes people do that. You'll see videos where they'll first cup, and that does two things. It marks an area, and it brings blood to the area. I don't do that, and I'll tell you why I don't do that. I don't do that because I don't know ahead of time exactly where I'm going to prick. So I don't know where to put it. So the way it works is I'll palpate around with my thumb, and I'll wait until I find the best spot. And I want that patient to say for sure. So if I go like this and I'm palpating, and he says, yeah, around there, that's not good enough. I keep palpating, and I'll go, oh, there. Okay, then I'm happy. That's where I'm going to start. So I'll prick there, and then I'll palpate around that spot to see if it's, you know, I need to go above it, below it, to the right or to the left. And then I'll find another spot. Oh, okay, there. And then I'll go there. And I'll do 4 or 5 of these, you know, within a 2-inch diameter, because that's the size of my cup. And then I see where I need to put my cup. Okay, let's see. 22 gauge is too small. 22 gauge too thin. Yes. So if the vein is superficial, would a lancet be sufficient? It might be. If the vein is very superficial, a lancet might be sufficient. But, you know, sometimes you'll see a video where somebody's really going after, I saw a video of somebody going after a vein in the arm with a diabetic lancet, and he pricks and pricks, and you can see the green vein, and he's pricking and pricking and pricking and pricking. And finally, he gets a little blood to come out. And it's not a good technique. I mean, with a decent needle, he could have gone boom and been done. But if you have those very dark, like probably on Eric earlier, you probably could have used a diabetic lancet. You'd want to stretch the skin, and then you could probably do it with that. But I'm telling you, really, a piercing needle or a hypodermic needle is a better needle for this, and you'll get a better result. So the higher the gauge, the thinner it is. Yes, the higher the gauge, the thinner it is. Western medicine uses a rubber band to help the veins to come out easily. Will you recommend to do it when the vein tends to go a little deeper than we would like? I don't use a rubber band. I mean, it's interesting how phlebotomists do that. And in phlebotomy, it's interesting because in phlebotomy, they don't go by actually the look of the vein. They're doing something different from what we're doing. They're not going after spider veins like we are. But the one time when they're doing something similar to us is when you're bleeding a vein in the crook of the elbow. Let's say lung 5, for example. So they choose a vein in the crook of the elbow. They learn to do it not by how it looks, but by how it feels. They want to find a vein that's full of blood. And in order to find that, you can do it better once you have that rubber band on. But I don't do that. It's more involved than what I really need to do. Okay, so on the back you are going on palpating versus visual, and on extremities looking, not palpating. Correct. Yes, that is exactly correct. In AccuNeedles, the 18 needle is smaller than the 20 millimeter needle. Not millimeter, gauge. I'm going by gauge. Okay, so you can go, it doesn't go, Is a 3 millimeter needle 30 gauge? I'm not sure. I don't know if it works like that. You can, Google gauge chart, hypodermic needle gauge chart, and you'll be able to find exactly what the diameter is for each gauge. And there's also something called piercing needles, which tattoo artists use, which we're going to talk about, which can also be used. They are essentially cut off hypodermic needles, and yet, interestingly, they have gauges too. Interestingly, that gauge, their gauge standard is different from the hypodermic needle gauge standard. So an 18 gauge hypodermic needle is not the same as an 18 gauge piercing needle. They're a little different, okay? And you can, again, just look those up. Just Google gauge chart hypodermic needle and gauge chart piercing needle, and you'll see that they're a little different. Okay. Okay, if you're dealing with joints, elbows, toes, wrists, etc., if there is pain but no visual, do you use palpating ever? I mean, there are times when I palpate for the legs. So, for example, there's a technique with knees. Now, usually with knees, you palpate for knee pain, you palpate and wet cup the upper back. There's a point, DT 0.07. Sanjin, I think it's called, in Masterdong bleeding. But there's a subset of knee patients, and it's especially the ones who complain about walking up or down stairs. And they won't respond to the spot on the back. They respond to direct needling or direct bleeding of the medial knee. And what you do is you have to palpate that medial knee, and if you find a spot that makes them jump, then you bleed there. And you wet cup. You wet cup there just like you would wet cup the back. That's not venous bleeding. Anytime you're palpating and finding a tender point, you wet cup there. That's not venous bleeding. That's a little different. All right, and sometimes that's true of the feet too. So, for example, we'll talk about it later, but you also bleed. You bleed. I've bled elbows for gout. You know, gout is usually in the feet, but it can be in any joint. And in that case, yes, you palpate, and you get as close as you can. Gout can be so painful, you don't want to bleed directly on the worst point, but you get as close as you can without killing the patient. Unless if you're in a state where you can inject, lidocaine, if you can numb the area, then you're lucky. Then you can bleed it directly. All right. Okay, so the back is capillary bleeding. That's wet cupping. The legs is venous bleeding, and the ears. The ears is capillary bleeding. You don't cup, obviously. We'll show how you bleed ears. Now, on the ears, sometimes there are these tiny little venules. You can bleed those too, especially behind the ears. You can bleed those. Honestly, with ears, I mean, there are different places to bleed. Personally, and sometimes people will say, well, if it's an eye problem, you want to bleed the eye area. The eye area is down here in the lobe. I don't, for whatever it is. I just bleed the apex of the ear. If it's going to work, it seems like it will work. If it's if it's something like trigeminal neuralgia that's extremely painful and I want to make sure I get the best result right away, I may bleed several points along, let's say the top of the ear, but I don't find that it's terribly important with the ear exactly where you bleed. The apex of the ear is fine. All right, so again, bleeding legs is venous bleeding. This is a picture of my patient who likes to spurt. And there I bled her, or I pricked that vein, and you can see it's very black, very dark blood that's coming out. So bleeding legs is venous bleeding, generally speaking, except like the exception. There are always, well, often there are exceptions. And bleeding, by the way, bleeding the medial knee, and we can talk about this a bit, this is something fairly new in my arsenal, and it's a discovery I made fairly recently. I haven't really seen that in any literature, but I'm doing it more and more, and it's so recent. I mean, the book that I wrote on bloodletting came out in August of last year, and it's not the bleeding the medial knee is not in there because I actually started doing it since then. But I've had really great results, and again, especially I started doing it for patients who, if I lay them down face down and I palpate the upper back, and I find that tender point, then they're going to respond, and I'll bleed it. But if they have a real bad pain in their knee, and they complain about climbing stairs and going downstairs, and I palpate their upper back, and there's nothing there, then I have them lie on their back, and I'll palpate the medial knee, and I'll generally find a really tender spot, and I bleed there. And to answer your question, sir, about how long it lasts, when you bleed the medial knee, it's really effective, and it really lasts a long time. I've had to do it, maybe 3, 4, 5 times. Each time it's better. But I have a patient, one of the first patients I did this for, like last October or something, September. And she was in Sweden, and she said she was diagnosed with plica syndrome, whatever that is. And nobody could help her, and she was quite overweight and in a lot of pain. Now, she still comes in every week or every other week for various other things, but I bled her maybe 4 or 5 times, that medial knee, and since then she has not had a problem. And even though she comes in, I don't bleed it anymore. After a little while, she said, I don't think we need to do the knee. I don't have any problem. Let's see. Any success with bleeding to resolve stagnant blood from intraocular bleed? Bleed near liver 3. Maybe I would bleed ear apex for sure for that. Lancet for knee. So Lancet, whether this is wet cupping. So the tool for wet cupping, we're going to talk about this, but I'll give you a quick preview. It's this thing. It's well, we're gonna see it. I don't know if you're seeing it right now, but anyway, these are safety lancets. These are the magic that makes wet cupping so easy, so acceptable to patients, so acceptable to you, and we're going to talk about that a lot. All right, so let's do a video. Can we do one video, Sam? So this is Linda. Let me set it up for you. So Linda is a patient who, she comes in, she's another patient who comes in for peripheral neuropathy. She's 77. She's a substitute school teacher. And I started off doing the infrared laser, and that worked pretty well. But then she has these amazing spider veins, so I started bleeding them. And every time I do that, she comes back, she says, that was really good. I really get a lot of relief every time you bleed my legs. I said, well, what's the difference between that and the peripheral and the laser? And she says, well, she came in recently. She said, I went dancing that night. She said, I love to dance. I haven't been dancing in years. That's how good I felt. I said, well, what really is the difference that you feel, between the laser and when I bleed? And she said, well, she said, she said, the laser, seems to make the pain better, but the bleeding really makes the pain better, and it also increases flexibility, she said. Somehow she didn't have flexibility before, and it really makes her flexible, really. And she was moving her toes and her foot and said, it doesn't hurt. So, all right, Sam, can we roll this? So this, I made this video last week or the week before, very recent. Yeah. All right, and I'm not sure if there might not be sound for this one. All right, so I'm looking for the very superficial one. There you go. 0.5 millimeter. 1 millimeter at most. Hardly anything. And it's plenty of blood. That's a successful bleed right there. And I'll just, I'll let it bleed as much as it bleeds. I may wipe it with an alcohol swab, just to make sure, just if I have time. A lot of it depends on time. If I'm in a hurry, I will not. If if she's the last patient of the day and I have time, I may keep swabbing. There you go, 0.5 millimeter. You can see I barely touched it. So again, when you bleed that way, they're not going to bruise. They'll experience the benefits. They will not experience any negative effects. And that's a happy patient. All right, so Carol writes, I did as you said about the knee bleeding. Oops, that disappeared. But anyway, I think Carol was saying that she had a very good result with a physician who was going to undergo knee surgery. Yeah, it is. That's why I love bleeding. You get these earth-shaking, these jaw-dropping results regularly. Okay, she has a lot of spider veins. Why did you choose that location? It looks a little different when you're right there. Somehow that was the darkest. Those were the darkest, most superficial veins. But you're right. There were a lot I could have chosen. Okay. So we're talking about bleeding the apex of the ear. That's capillary bleeding. And it is the quickest and the easiest type of bleeding. You just squeeze up a little skin at the ear apex. I like to do that. You don't have to do that. But, as a general rule, you want to cause as little trauma as possible. So if you just, prick into the cartilage, that's fine. The cartilage will heal. But to me, it's a little cleaner to pinch up the skin and avoid the cartilage. So I try to do it that way. You can prick with a lancet, a manual lancet, or a safety lancet. The 17 gauge, and remember, the smaller the number, the bigger the lancet. 17 gauge is the biggest diabetic lancet you can get. You can't even get the manual ones that size. It's just the safety lancets like this. They come in 17 gauge, and that's what I use for the back. And you can use those for the ear, and I've done it, but for my taste, it actually works a little too well for the ear. It takes a while. I don't want to say it's hard to stop the bleeding because it's not that bad. There's no panic involved. It'll stop. But if you've got a constant flow of patients and you've got to keep people going and you can't wait forever for this thing to stop, I actually prefer to use 21 gauge manual lancets for the ear. I'll show you those. Because that, to me, strikes the right balance. You get plenty of blood, but you can also stop it pretty easily. Okay, so here's the next question. How much blood do you need when bleeding the back, the legs, or ears? So this question is based on a mistaken notion that you control how much blood comes out, and that's not so much true. You'll see my patient who I pricked and she spurted for 8 minutes straight. I mean, that was not my technique that made that happen. It was her body. I mean, if any of you had pricked that vein, the same thing would have happened. And I think, when I first started bleeding, if I would prick a vein and I didn't get much blood, I would think, oh, what am I doing wrong? This is my fault. And then after a while, as I got more experience, I realized it doesn't really depend on me. And phlebotomists, say the same thing, basically. That's why they palpate veins to see which one has, the most blood in it. Because, I was talking with a phlebotomist about it, and she says, well, if I don't do that, she says sometimes, so they have these vacuum tubes, and they put them in, and it sucks the blood. And she says, if I don't do that, sometimes I'll have a vein that looks very good. It looks, like there's blood in it, and I'll pierce that vein, and the vacuum, nothing will happen. It'll just close the vein. There's no blood in that vein. So you don't know by looking how much blood is in there. One thing that's surprising is those tiny little veins can carry more blood. I mean, they usually carry a lot of blood. You usually get, those videos that I showed you so far of Eric and Linda, those are not cherry-picked videos. That's what happens when you bleed those, those tiny little spider veins that look like that. You always almost get that much blood. Sometimes you'll bleed a big green vein, and you won't get that much blood. But anyway, mostly it's the body that will determine how much blood you get. You can increase it, as I've shown, by swabbing with an alcohol wipe. And again, you don't need much. Effectiveness is not dose dependent. A drop the size of a large bean will do the job. Okay. Which symptoms are relieved by apex bleeding? We're going to go into that. Pretty much all the things. Let's see: dental pain, sinusitis, insomnia, foggy. Would you bleed ear apex for dysphagia, trouble swallowing in a case with no stroke or other physical reason? So here's the thing with bleeding the ears. I don't know everything about bleeding the ears. People come in with all kinds of weird complaints. But if it's anything in the head, almost anything, within the rib cage or above, but certainly anything in the neck or head, I will bleed the ear. It's one of the first things I'll do. Why? Because it may work, and it may work a miracle. And if it doesn't work, so what? What have I lost? Every decision in life at the end of the day comes down to risk versus reward, right? And the risk versus reward of bleeding the ear is, it's like this. The risk is almost zero. It's quick. It's easy. If it doesn't work, you've accomplished something. If you bleed the ear and nothing happens, you've accomplished something important, which is you've ruled out blood stasis. Okay, so with that patient now, as you proceed, you know that bloodletting it's not a blood stasis case, it's something else. So when I bleed ears, it's not just therapeutic, it's also diagnostic. That's why any time that it might work, that it's something in the head or something in the neck or something even in the chest, I'll bleed the ear right away, partially just to find out if it is a blood stasis for diagnostic purposes, to see if it's a blood stasis case. So I'll always tell people, before I bleed their ear, I'll always tell people, okay, I'll tell them I'm going to poke your ear, I'm going to try to get out a drop of blood, and if I can get out a drop of blood, it may relieve the symptoms right away, and also it'll tell me a lot about the nature of your case, and it'll help me tell me how to proceed in the future. So, and I always get a baseline, and I say, so I'm really interested in knowing if there's any change right after I do this. So what is the pain like right now? Or what is the discomfort like right now on a 0 to 10? And they'll tell me, and I'll say, okay, now get a good sense of how that feels. Move your arm. Get a sense of that shoulder, or try to swallow, or whatever it is. Because I'm going to ask you right afterwards to compare it and tell me if there's any change. Okay? Okay. So for dysphagia, you bet I would bleed the ear. It's probably the first thing I would do. I would want to know if it helped or not. Would you do just one side? If it's a right-sided symptom, I would do one side. If it was both sides, I would do both sides. If it was sort of in the center, I might do both sides as well. At one point, do you ever bleed two areas? Yeah, I do. For sciatica, we'll get into this. I may bleed the upper back sciatica area, and I may bleed the leg. And I would certainly bleed, both ears. Or, yeah, I would bleed more than one area. Oops, somehow I went backwards here. All right, so let's talk about the blood stasis type of patient. So there's a certain type of patient who tends to develop blood stasis. I love these patients because I can always bleed them. Okay, so I always want to know if somebody's a blood stasis type, and if they're a blood stasis type, to me that's a relief because I think I'll probably always be able to treat them pretty easily and pretty effectively. So how do you know if somebody's a blood stasis type of patient? Well, if somebody has ever responded to bloodletting, they are a I categorize them as a blood stasis type, as somebody who is prone to developing blood stasis. So what does that mean? You could say they have a blood stasis prone constitution. So that means, what does that mean? That means that the next time they come in, if they have a complaint, no matter what that complaint is, even if it is completely unrelated to the initial complaint they came in for, the first thing I'll do is bloodletting. Now there are some complaints that are, there are some things that almost always respond to bloodletting, like nausea. Some things that usually will respond to bloodletting, like sciatica. And then there are some things, sometimes it's a blood stasis problem, and then it'll respond like magic to bloodletting. Sometimes it's not a blood stasis problem, and it won't respond to bloodletting. And it's very hard to tell without trying. An example of that would be plantar fasciitis. You can have two people come in with the same presentation, the same plantar fasciitis, the same pain in the heel, and one you'll bleed them, and it's like they'll stand up and step on it. They'll say, wow, that's incredible. And the other one, they'll stand up, they'll say, nah, it's about the same. So, if somebody comes in with plantar fasciitis, I may or I may not bleed them on the first appointment. But if I've ever bled them previously, successfully, then you bet I'll bleed them on the first appointment, because that's a blood stasis type patient, a blood stasis prone constitution. And for that patient, bloodletting, blood stasis is the first suspect, and bloodletting is the first thing I would try. Yes?
For plantar fasciitis, where do you bleed them?
So on the legs. And
on the leg?
Yeah, whoops. Okay. Sorry, that's my alarm. I have to take this right now. I started to get sick last night, so I have to take my magic stuff. So I'm able to finish this day. All right. So, yes, where do you bleed on the leg? So you bleed, the classic point to bleed for plantar fasciitis is UB40. But again, if they don't have great veins at UB40, so that's the first place you look. If you find nothing there, but there are great veins on the stomach 36 area or lower leg or even on the thigh, then you bleed there. So again, it really depends. The areas will tell you where to look first, but the final decision depends on what you see. Okay. For left shoulder, do you bleed the left ear or right? Ipsilateral. For the left shoulder, you bleed the left ear. I will also like to have this magic stuff. Will you be kind enough to tell us? Okay. So, I'm not selling this stuff, so I guess I can talk about it. So this is called ProBoost Thymic Protein A. And this is the magic stuff. And you can't get it in a health food store. I wanted to sell it in my clinic, but the company that makes it will sell it directly to retail. They don't sell it wholesale for some strange reason. So you can go on Amazon and you can get it. But this stuff is magic. And I always have it with me because the trick is you have to take it like within the first, just as you're feeling sick, or it doesn't work. And then once you take it, you have to take it every 4 hours for the next 3 days. That's the tricky part, because after a while you're going to feel fine, or you're going to say, I was just imagining it, and you won't take it, and then you'll get sick. So that's why I set this. I've learned through hard experience, the school of hard knocks, that if I don't keep taking it, if I'm not disciplined, I'm going to get sick. So that's why
What is that?
this is ProBoost. It's called ProBoost Thymic Protein A. ProBoost. Okay. Dennis, it's magic. So you know about it too, Dennis? It is really magic. It is really, really good stuff. All right. Yeah, sure. Well, let's do, what slide number is this? Can you tell? $30? Okay, we can do 10 minutes, I guess.
Okay, guys, let's go ahead and take a 10-minute break, and we'll return here at 10:45.